Hi friends, in this lecture we'll try to understand the anatomy of the diaphragm. This is Dr. Yusuf signing from Saudi Arabia. The diaphragm, it is defined as a dome-shaped musculo as well as the aponeurotic partition. It is muscular as well as the aponeurotic partition which intervenes between the thorax and the abdomen. So if you can see here in this picture, this is the thorax and below will be the abdomen. These two are separated by a dome-shaped muscular partition which is muscular as well as aponeurotic. This part which is shown in whitish color, that is called the aponeurotic part, and which is shown in the brown color, that is the muscular part. So it has both the muscular as well as the aponeurotic partition muscle which is separating the thorax from the abdomen. This is only seen in case of the mammals, and this has a thoracic surface which is convex. So the thoracic surface is the thorax. So the thoracic surface is convex. It is dome shaped. It is double domed on the right side as well as on the left side, with a depression in between the two domes, the right and the left dome. The convexity on the right side is much higher because of the presence of the liver, which will be pushing the dome much more higher in position. This is because of the presence of the liver here. Okay, so this is called as the pole. Okay, summit of convexity is maximum on the right side compared to the left side, and in the between it is depressed, slightly depressed, and the heart will be sitting on that part. Okay, the central part is tendinous, as I said. The peripheral part is muscular part, and the central part, this is called as the central tendon. Okay, the central part is tendinous and that is called as central tendon. The peripheral part, as I said, it is muscular and it is, as I said, it is skeletal muscle, so it is striated. Okay. The origin of this muscle, first we will see the origin of this muscle. The origin is the oblique circumference of the inner surface of the thoracic outlet. So here is this is the thoracic cage, this is called as the thoracic inlet, and this below, this will be called as the thoracic outlet. Okay, so the oblique circumference of the inner thoracic outlet, so throughout the outlet this muscle will take its origin. Okay, the three groups, it is divided into three groups how it takes origin. From some fibers will be coming from the sternal part, some will be coming from the costal part, and some from the vertebral part. So the muscle, the part of the muscle which is taking origin from the sternum, it will be in the form of two fleshy slips back of the xiphoid process. So this is the xiphoid process. This is the manubrium sterni. This is the body of the sternum. This is the manubrium part, and this is the xiphoid process. Okay. So this is called as the manubrium sterni, and this is the xiphoid process. On the back side or the inner surface of the xiphoid process, the muscle will be taking origin as two fleshy slips. Okay, so from here it will be taking origin. This is called as the sternal part. Then the costal part, this whole thing is the costal margin. So the muscle fibers will be taking origin from this costal margin also. Okay, the rib part as well as the costal cartilage. This bluish structures which are shown, these are the costal cartilages, and this lowermost part, this is called as the costal margin. Okay, so the inner surface of the lower six ribs, there are 12 ribs, there are 12 pairs of ribs. So the lower six ribs, it will take origin from the inner surface, okay, from the lower six ribs and the costal cartilage. So this is the costal bluish cartilage, this is the costal cartilage, as well as these are the ribs. All these are the ribs. So it takes origin from the lower six ribs as well as the inner surface of the costal cartilages, interdigitating with that of the transverse abdominis. As you know, the abdominal wall has three layers. The innermost will be called as the transverse abdominis. This is the transverse abdominis. There is external oblique, the internal oblique, and this is the transverse abdominis. Three layers on the lateral side. So this is the innermost. So this fibers of the diaphragm will be interdigitating with that of the transverse abdominis. Okay. And the third part of this muscle which will be taking origin will be from the vertebral part. So here if you can see, this is the xiphoid process. This is the picture seen from below, from the abdomen, showing you the diaphragm. This is the diaphragm here, showing you the diaphragm, the peripheral, the skeletal part, and the central tendon. This is the aponeurotic part, which is called as central tendon. So this is a picture seen from below, from the abdomen, seeing the diaphragm directly. So this is the xiphoid process of the sternum. So some fibers will be taking origin from the xiphoid process, some fibers will be taking origin from the costal cartilage, as well as the ribs. Okay, so the costal margin here, this is the costal margin, and here will be the ribs. So it will be taking origin from all the parts here, or from around. Okay, especially near the thoracic outlet, as well as some fibers also take origin from the, this is the vertebra. Okay, the lumbar vertebrae here, which you are seeing, the first, second, third, and fourth lumbar vertebrae. Okay, so these are the three sources from where it will be taking origin. Okay, so from the vertebral part, they are taking origin in the form of a pair of crura. If you see here, this is called as the crus, right crus and the left crus. Okay, when it is singular, it is called as crus. When it is more than two, then it is called as crura. Okay, so when they are in multiple, then it is crura. When it is single, it is called as crus. The right crus and the left crus. So a pair of crura, right and left, that is the right crus and left crus. The right crus, this is the right crus. It is longer, more muscular, and from the upper three lumbar vertebrae. The first lumbar vertebra, as I said, they have been numbered here. Second lumbar vertebra, and the third lumbar vertebra, and the fourth. So 4 have been shown. So this right crus of the diaphragm is taking origin from the upper three lumbar vertebrae. Okay, and displaced during inspiration, suspensory muscle of the duodenum. Okay, coming to the left crus. So this is the left crus here. It takes origin from the upper two lumbar vertebrae. This was from the upper three. So this will be taking origin from only from the first and second, not from the third. Okay, so the left crus is smaller compared, slightly smaller compared to the right crus. Okay, and the bare area by the gastrophrenic ligament, which is present there. Okay, and both are connected by the median crurate ligament. So in between them, there are two, both are connected. The right crus and the left crus are connected by a ligament here. This is called as the median arcuate ligament. Okay, this is the median arcuate ligament, and behind that will be the aorta. We'll talk about that later. Okay, aorta as well as the thoracic duct. So this is the right crus and the left crus. So this part will be called as the vertebral part, which is taking origin. This is the origin of the diaphragm. Some part will be taking origin from the sternum, some will be taking origin from the costal cartilage as well as the ribs, and some part will be taking origin from the vertebra itself. Okay. It also has between, as I said, between the two crura, there is something called as this is the median arcuate ligament. Similarly, lateral to these cruras, or the right and left crus, there is again extension of the same. This is called as the pair of median arcuate ligament. What it was, this previously it was median. Okay, so this is the median, this is medial. Okay, the difference of L and N. Okay, you should know. Median means at the center, medial means beside the center. Okay, so this is the medial. Okay, so this is the medial arcuate ligament beside. This is the median arcuate ligament in between the right and left crus. This is the median. Okay, and beside the median, that is the medial. Okay, so this is the medial arcuate ligament, also called as the medial lumbocostal arc. Okay, and bridges in front of the psoas major muscle. Just behind that will be the psoas major muscle here, which is taking origin. Okay, here was we saw that it was the aorta behind the median. Okay, behind the medial will be the psoas major muscle. Okay, and formed by the thickening of the psoas fascia. Okay, and this arch is formed by the thickening of the psoas fascia itself, as well as part of the diaphragm. Okay, attachment medially. This is about the medial arcuate ligament. Okay, so medially it is attached to the first and second lumbar vertebrae, that is through the left crus. Okay, and lateral side it will be attached to the tip of the transverse process. These are the transverse processes of the lumbar vertebrae. So this is attached to the lateral process of the first lumbar vertebra. Okay, so on the both the sides, you can see it on the both the sides. Okay, here medially it will be attached to the first, second and third lumbar vertebra. On the left side it will be just first and second. On the right side it will be attached to three, first, second and third, and laterally it is attached to the transverse process. So this is called as the medial arcuate ligament. Beside that there is a larger one. This is called as the lateral arcuate ligament. On the lateral side there is the lateral arcuate ligament. This is also pair and this is called as lateral lumbocostal arc. The arc is in front of the quadratus lumborum. So here was psoas major muscle, and beside that will be the quadratus lumborum. So this arc will be covering the quadratus lumborum, formed by thickening of the anterior layer of the thoracolumbar fascia. Okay, and this is formed by the arc is formed by the thickening of the thoracolumbar fascia. Okay, attachment medially we have seen it is to attach to the same transverse process. Lateral tip, the tip of the transverse process of the first lumbar vertebra. Laterally it is attached to the 12th rib. 12th rib. It is attached to the 12th rib. Okay, laterally it is attached to the 12th rib. This is about the median arcuate ligament, medial arcuate ligament, as well as the lateral arcuate ligament and the structures behind them. In the median arcuate ligament there will be the aorta as well as the thoracic duct. Behind the medial arcuate ligament there will be psoas major, and behind the lateral arcuate ligament there will be the quadratus lumborum. So this is how that muscle will be taking origin. One part from the sternal part, that is behind the xiphoid process. The second part will be from the costal margin as well as the lower 6 ribs, and the third part from the vertebral part, it will be taking origin from the first, second and third lumbar vertebra on the right side, on first and second on the left side, the form of crura, and this crura will lead to the formation of median arcuate, the medial arcuate as well as the lateral arcuate ligament. Median arcuate ligament is single, but the medial and lateral will be in pairs. Okay, median is only one. Okay, now coming to the insertion of this muscle. Okay, so this was all the origin of this muscle. Now all the fibers from all these areas, from the sternum, from the costal cartilage as well as rib as well as the vertebrae, they all go toward the center at near the dome. Okay, and all fibers to the central tendon at the median depression part of the diaphragm. So all these fibers will go to the central tendon, and they all connect to each other in the form of the fiber that is the central tendon. Okay, so this will be the central tendon where all the fibers will come and get inserted. Okay, so this is the insertion of this muscle to the central tendon itself. Okay, and it is, this part will be slightly depressed. Okay, shape of this central tendon, it is like trefoil leaf appearance presents, and median leaflet, right leaflet as well as the left leaflet. So this central tendon will have it looks like a trefoil leaf, and it presents with median leaflet, the right leaflet as well as the left leaflet. So this is the median leaflet, the center. Okay, so right leaflet and the left leaflet. So this is called as the trefoil leaf like appearance. Okay, the central fiber, the sternal fibers are short and the fibers from the 9th costal cartilage are the longest. Okay, the sternal fibers which are coming from the sternum, this will be the shortest, and the fibers coming from the 9th costal cartilage will be largest. Some fibers are long, some are short, depending on from where they are coming. The central tendon is very near to the xiphoid process, so the fibers are very short. The fibers coming from the 9th costal cartilage will be very much away, so the fibers have to go run all the way up to the central tendon, so they have the longest. Coming to the openings of the diaphragm, the muscle, as you know, it is separating the thorax from the abdomen, but there are some openings through which some of the structures will enter from the thorax into the abdomen, or some fibers will be entering from the abdomen to the thorax. Okay, so there are two types of openings. There are major openings as well as the minor openings. The major openings are 3 in number. The first one is called as the vena cava opening. So vena cava vena cava opening, because there is inferior vena cava, so that's what is called as the vena cava opening. The second is called as the esophageal opening. This is the esophageal opening. Then we have the third opening, that is called as the aortic opening. The third we have already seen behind the median arcuate ligament. So this is the third opening, that is the aortic opening. So there are three openings, major openings: vena cava openings, esophageal openings, and the aortic openings. So they are named as VOA, Voice of America, to remember it easily. V stands for vena cava opening, O for esophagus. Esophagus can be written with starting with O or with E. Okay, according to the British way of writing, it will start with esophagus O. Okay, like this, OE. But according to the American standards, it starts with E. Okay, so if you remember it as O, then VOA. E stands for aorta. Okay. So this is important, because if you remember VOA, so you should know that these will be opening at different levels. Okay, with relation to the vertebral column itself. So this will be opening V, that is the vena cava opening, will be opening at the level of 8th thoracic vertebra. The esophagus will be opening at the 10th thoracic vertebra, and the aorta will be opening at the 12th thoracic vertebra. So this is important and can be easily remembered if you remember VOA. So it is 8th, 10th and 12th thoracic vertebrae. Okay, at which they will open into the abdomen. Okay. Starting with the first one, the vena cava opening situation. As I said, it will be in the central tendon. So you can see as in the picture, it is in the central tendon itself, junction of the medial as well as the right leaflet. So this is the medial leaflet and right leaflet. At the junction will be the inferior vena cava, and it will be opening into the actually this is the venous drainage from the abdomen and the lower part of the abdomen. So it is opening into the thorax, and from there into the heart itself, the right atrium. Okay, so this is opening at the level of the 8th or to the 8th to 9th thoracic vertebra. To remember it easily, you can number it as 8th. But it is between the 8th and 9th thoracic vertebra. Okay, and this is not at the exactly at the center of the body. It is 2.5 centimeter from the midline, 2.5 centimeters to the right side of the midline. Okay, the shape of this opening is almost quadrilateral. What are the structures passing through this opening, vena cava opening? The main opening, as the name indicates, vena cava, that it is the inferior vena cava, which will be opening. And the wall will be adhered to the fibrous ring. Around the wall of this vena cava will be totally adherent to the fibrous ring, which is formed by the central tendon. Few fibers of the right phrenic nerve also come through this way. If you can see here, this is the right phrenic nerve, which is also coming along with this inferior vena cava. And few lymph vessels from the liver will be entering into the thorax from the abdomen. The vena cava will be entering from the abdomen to the thorax, as well as the few lymph vessels from the liver will be entering into the thorax from the abdomen. And the phrenic nerve, right phrenic nerve, will be entering from the thorax into the abdomen. Okay. What are the effects of this contraction? If the central tendon contracts and if the diaphragm contracts, so during respiration, as you know, it is a very important muscle of respiration. So whenever it moves, what happens exactly to the vena cava? Okay, so the effect of contraction of this opening will be, it dilates and more blood to the right atrium will be happening. So it will push the blood from the abdomen as well as the lower limb into the right atrium of the heart, especially during inspiration. Okay, so this, whenever there is contraction, so it pushes the blood into the heart, to be precise. Okay, so it helps in the pulling of blood from the lower part of the abdomen, because it has to go against the gravity. So contraction of the diaphragm itself helps a lot in pushing the blood from the lower part of the body into the heart itself. Okay, the second important major opening is the esophageal opening. This is the esophagus here, so this is the esophageal opening. Suture, it will be present in the muscular part. As you saw, the vena cava was in the central tendon, but the esophageal opening is in the muscular part, and it opens, as I said before, at the 10th thoracic vertebra. VO, okay, 8/10th, okay, and it is almost 1.5 centimeter, 1.25 centimeters left to the midline. As you know, in case of the thorax, it will be towards the left side, and when it enters, it will be coming more toward actually it will be on the right side, and slowly it will be entering into the left side when it enters into the abdomen, and then in case of abdomen it opens into the stomach, and stomach is mainly on the left side. Okay, so this will be slightly, before it becomes totally on the left side, it is slightly becoming the left side, so it is almost 1.25 centimeters to the left of the midline. Okay, this was towards the right side, and this esophageal opening is towards the left side. Okay, shape and function this opening, it is elliptical, as you can see here, formed by the splitting fibers of the right crust. Okay, this is the right crust, so the fibers of this right crust split, and they will have this opening for the esophagus. Okay, so what are the structures passing along with that of the esophagus? As the name indicates, the esophagus is the main structure which will be passing through this opening. Along with that, what else will be passing? So the first one is esophagus itself. Then along with that, the anterior and posterior vagal trunks forming respectively from the left and right vagus. If you can see here, this is the right vagus and this is the left vagus. Okay, once it enters into the abdomen, they rotate and they become anterior and posterior. Instead of right and left, they become anterior and posterior vagal trunks. Okay, vagal nerves or vagal trunks. Okay, so here in the picture they are still showing they are on the right and the left side, but once they enter the abdomen, they become anterior and posterior. Okay, depending on the position they change. Okay, then along with this, the esophageal branch of the left gastric artery and venous tributaries also pass through this. Okay, esophageal branch of the left gastric arteries enter through this opening, and it will be supplying the lower part of the esophagus. Okay, so that is the esophageal branch of the left gastric artery. Along with that, the venous tributaries also will be passing. Then the lymphatics from the liver. The lymphatic will, as you know, the liver will be on the left side, pushing the dome of the diaphragm. So some of the lymphatics which are coming from the liver also will be draining into the thorax through this opening. Okay, then phrenicoesophageal ligament will be also there. Okay, so that is the small ligament which will be holding the esophagus. Okay, which will be connecting the diaphragm itself with the esophagus. This you can appreciate when you study the development itself. Coming to the effect of contraction. So the effect of contraction of this is it prevents regurgitation of food. As I said, the esophagus will enter here and opens into the stomach, and all the food will be collected into the stomach. So whenever the food tries to regurgitate, so this muscle, the diaphragm, will contract, and this opening becomes narrow and prevents the regurgitation of the food particles. So this has a very important role in the prevention of the regurgitation of the food particles, especially when you lie down or jumping or something like that. It can regurgitate back into the esophagus. So this opening, whenever the diaphragm contracts, it will collapse, the opening will constrict, and that leads to the narrowing of the esophagus itself, and it prevents the regurgitation of the food particles. The third and the last opening, major opening, will be the aortic opening. So it is behind, so the VOA. So this is the aorta. Okay, so the thoracic aorta enters into which is coming from the left side, enters into the abdomen. Okay, so and it is coming towards the center. Okay, and entering into the abdomen and continues as the abdominal aorta. Situation behind the diaphragm. Okay, so those were within the diaphragm. One was in the central tendon, vena cava. Esophagus was within the muscle, and now this is behind the diaphragm itself. So it will be forming the osseo-aponeurotic. Okay, so partly it will be aponeurosis, and behind will be the bone itself. Okay, and this will open, as I said before, at the 12th VOA, 8, 10 and 12th thoracic vertebra at the lower border, and lie slightly left of the median plane, slightly left still, but once it enters it will come into the midline, almost in front of the vertebra itself. Okay, shape, it is almost rounded. Okay, and boundaries, front we have the median arcuate ligament, as we have already seen. There will be the right crus and the left crus will cover this whole opening, and that is called as the median arcuate ligament. Behind will be the 12th thoracic vertebra, as you have seen already. Okay, so we have already seen, here will be the 12th thoracic vertebra behind. This is the first lumbar vertebra, before that will be 12th thoracic, and this is the median arcuate ligament in the front. Behind will be the 12th thoracic vertebra, and on each side will be the corresponding crus. On each side we have the crus. Right, on the right side we have the right crus, on the left side we have the left crus. Okay, so this is about the boundaries of this opening. Okay, what are the structures passing? One is, as you know, the name itself indicates, it is the aortic opening. So the thoracic aorta becomes the abdominal aorta here. Okay, so one is the abdominal aorta, the second is the thoracic duct. Beside that will be the thoracic duct. If you can see in this picture, they have shown the green colored structure. This is the thoracic duct. This is the main lymphatics which are draining from the abdomen into the thorax, into the thorax through the thoracic duct. Okay, so the abdominal aorta, from left to right side, it will be the aorta itself. Then we have the thoracic duct, and sometimes even the azygous veins. Azygous vein, if you can see here in this picture, they have shown the azygous vein. Sometimes it will be into this opening itself, sometimes it will be piercing the muscle, sometimes it will be directly into this opening. Okay, so sometimes the azygous vein also. So what is the effect of contraction? No effect at all, because it is the aorta, so the blood has to be pushed from the thorax into the abdomen to all the parts. So contraction, because it is mainly aponeurotic here, so it doesn't lead to much compression of the aorta itself, and it doesn't have to be compressed. Okay, because it has to push the blood into the abdomen, so there are no effects of the contraction of this aortic opening. So these are the three openings. One is the vena cava opening, esophageal opening, and the third was the aortic opening. These are three major openings. Along with that, there are many minor openings. Okay, so one is called as the space of Larrey, which is a triangle between the orifice and from the 7th costal cartilage. Transmits superior epigastric vessels, few lymphatics from the liver, and it also forms the foramen of Morgagni when it is enlarged. We'll see the foramen of Morgagni. So this is the space where there will be a small space, okay, where the superior epigastric artery will be entering. Okay, so superior epigastric artery as well as few lymphatics from the liver. Okay, so this is called as the space of Larrey. Okay, small space on either side which will be there, through which the superior epigastric artery vessels as well as the artery and veins as well as few lymphatics on the liver will be passing. Okay, and it is a triangle between orifice and from the 7th costal cartilage. Okay, small space, that is called a space of Larrey. This is important when it is enlarged and clinically important. Then it is called as the foramen of Morgagni. We'll see that later, okay, when we talk about the applied aspect or clinical aspects. Between costal orifice and the transverse abdominis also there is a small space through which lower 5 intercostal vessels and nerves will be passing. Okay, so between the transverse abdominis will be the abdominal muscle. Okay, the innermost abdominal muscle. So between the costal orifice and the transverse abdominis there will be some of the blood vessels and nerves will be passing. The lower 5 intercostal vessels and nerves will be passing through. Okay, so that will be called as the second space, minor space. Between the costal orifice from the 7 to 8 costal cartilage, there is the musculophrenic vessels which will be entering again. The musculophrenic nerve, which is the main nerve which will be supplying the dome of the diaphragms, so that will be entering between the costal orifice from the 7 to 8 costal cartilages. Okay. Then behind the lateral arcuate ligament, we have already seen the lateral arcuate ligament was here. So this is the lateral arcuate ligament. Okay, and behind that we have the subcostal vessels and nerve will be passing. Okay, subcostal vessels and nerves will be passing behind the lateral arcuate ligament. Then behind the medial arcuate ligament, sympathetic trunk as well as left anterior splanchnic nerves will be also passing. So beside the medial, we have the splanchnic nerves which will be entering from the thorax into the sympathetic trunk, as well as even the sympathetic trunk will be here on either side. Okay, sympathetic trunk as well as the anterior splanchnic nerves. Okay, piercing each crus will be the greater and lesser splanchnic nerves. Piercing the crus will be the right and the left gastric splanchnic nerves here. Okay, these are the great splanchnic nerve and the lesser splanchnic nerve. So the greater and lesser splanchnic nerves will be piercing the crus on their left side as well as on the right side. Okay, along with that, the right crus will be pierced by the azygous vein, as we have seen. Sometimes it passes through this opening, sometimes it passes through the right crus itself. And the hemiazygous, inferior hemiazygous will be passing through the left crus. So this is the inferior hemiazygous. Superior hemiazygous will be coming from the thorax. Okay, then the left cupula. Okay, left phrenic nerve. So from the cupula means the dome of the diaphragm. Okay, from the left cupula will be the left phrenic nerve. Okay, on the right phrenic nerve, as we saw, it will be entering into the abdomen through the inferior vena cava. So it is not piercing the diaphragm. Okay, so only the left phrenic nerve will be piercing the dome of the left side. Okay, so this is all about the openings, the major openings, 3 openings here. Inferior vena cava, esophagus as well as the aorta, and there are many multiple small minor openings. Okay, so this is about the openings. Now talking about the nerve supply, the nerve supply of this diaphragm is by the phrenic nerve. The phrenic is the Greek name which indicates, phrenic means diaphragm itself. So it is the nerve to the diaphragm that is called the phrenic nerve. It is a motor nerve because, as you know, this is a skeletal muscle. It is motor, but the phrenic nerve is a mixed nerve with the root values C3, C4 and C5. The right phrenic, so as you have seen in the picture previously, the right phrenic and the left phrenic. So there are 2 phrenic nerves which are supplying this diaphragm. The right phrenic will be supplying the whole of the diaphragm up to the right margin of the esophageal opening, up to this margin. So this whole part, the right side of the diaphragm, will be supplied by the right phrenic. The left phrenic will be supplying the whole of the diaphragm, the left side, up to the opening of the left margin of the esophageal opening. So it means the 2 phrenic nerves will completely supply the whole of the diaphragm. Okay, the right crus is supplied by both the phrenic nerves. The right crus, as you have already seen. So this is the right crus because some of the fibers will be going on the left side. So that's why even the right crus is supplied by both by the right phrenic. This is the right phrenic and also the left phrenic. Okay. But the left crus is only supplied by the left phrenic because the left crus is totally on the left side, so it is mainly supplied by the left phrenic nerve. Okay, the sympathetic supply is from the celiac plexus via the inferior phrenic plexus, and this sympathetic supply is mainly to maintain a tone by lessening the fatigue. Okay, so if the diaphragm gets fatigued, then it is difficult to respire, so it decreases the tone of by lessening the fatigue, so it maintains tone. Okay, so which is important in case of the respiration. Coming to the sensory supply, the central part by the phrenic nerves and the peripheral part by the lower 6 to 7 intercostal nerves. The intercostal nerves which are supplying will also are mainly sensory. Okay, so they will take the sensation from here. Okay, from the 6 or 7 lower intercostal nerves, along with the central part which is mainly by the phrenic nerve itself. Okay, so there is the nerve supply. The main supply is by the phrenic nerves. Along with that, there is sympathetic supply also. the posterior intercostal arteries itself, which are passing through the intercostal spaces, also supply the lower fifth, 5 or 6 posterior intercostal arteries also supply the diaphragm, along with the phrenic artery itself, the last branch of the descending thoracic aorta. So that is the superior phrenic. Superior phrenic will be the last branch coming from the thoracic aorta before it enters through this opening, aortic opening, and become the abdominal. So that will be the superior phrenic. And inferior phrenic, in this picture you can see, as soon as it enters the abdomen, the aorta again gives the inferior phrenic artery. Okay, so this is the inferior phrenic artery, which can be seen from the abdomen, and the superior phrenic artery can be seen from above, from the thoracic cavities. It will be similar to this. Okay, so on either side it is a pair. So on either side it will be supplying, the inferior phrenic artery will be supplying from below, coming, which is a branch from the abdominal aorta itself, and the superior phrenic, which is a branch from the thoracic aorta. Okay, and it will be supplying all these arteries will be supplying the whole of the diaphragm. Musculophrenic as well as pericardiophrenic arteries coming from the internal thoracic artery, the posterior intercostal arteries lower 5 or 6, then the superior phrenic artery as well as the inferior phrenic artery. All these arteries will be supplying the diaphragm itself. Venous drainage corresponds to all these arteries. The names of the veins are similar to that of the arteries. Okay, so they correspond to arteries. Coming to the actions of the diaphragm, okay, one is on the thoracic cavity itself. As you know, this is the principal muscle of inspiration. Okay, so whenever the diaphragm moves, it helps in respiration. Whenever the diaphragm moves downwards, then it pulls the whole of the diaphragm contracts, and that leads to the lower ribs, fixing of the lower ribs. Then the vault of the diaphragm descends, the central part will descend downwards, so the diaphragm will move downwards. Vertical diameter of the thoracic increases, so the vertical diameter of the thoracic cavity increases. Upper abdominal viscera displays downwards, so there is pressure created within the abdomen, and the upper abdominal viscera will move downwards, and the anti-abdominal wall bulges forwards. The abdominal wall bulges because of the pressure created within the abdomen. Okay, further contraction leads to lower ribs elevation. So if there is further contraction, so that will lead to the lower ribs which are elevated. This will lead to increase in the anterior-posterior diameter as well as the transverse diameter. So it is called as the bucket handle movement if you have studied. So it increases the anterior-posterior as well as the transverse diameter. So that also increases. So one is the vertical diameter as well as transverse as well as the AP diameter, all increases, which help in the bulging of the thoracic cavity itself, and that leads to the expansion of the lung and pulling of the air. Okay, so a negative pressure is created in the lungs and the air is pulled inside. In case of quiet breathing, it will be the movement of this diaphragm will be almost 1.5 centimeters, but in case of deep breathing it goes up to 6 to 10 centimeters in the movement. Okay, and the total surface area created will be 270 square centimeters, and almost 400 to 500 ml of tidal air enters lung because of the diaphragm itself. Okay, so the muscle, the diaphragm is the main principal muscle of the inspiration, and this will help in creation of almost 400 to 500 ml of tidal air which enters the lung because of the diaphragm itself. Second thing, on the abdominal cavity itself, the pressure, the action of the diaphragm on the abdomen. What happens if the diaphragm is moving and creating a pressure within the abdomen? Increased intra-abdominal pressure will lead to vomiting, micturition as well as defecation. All these movements, conditions where the pressure is created by the diaphragm itself will help in the vomiting as well as micturition and defecation. Okay, so pressure is created within the abdomen which leads to vomiting, micturition, defecation. And on the three major openings, the inferior vena cava, the esophagus as well as aorta, as you have seen, it will be having its own effect. We already studied on the aorta, it doesn't have much effect, but in case of esophagus, it prevents the regurgitation by contraction of this opening itself and the contraction of the esophagus itself, as well as in case of the inferior vena cava, it creates pressure so that the blood is pushed from the abdomen into the thorax. Okay, the effect of posture on the movement of the diaphragm. What are the effects of posture on the movement of the diaphragm? One is, in case of the relaxed diaphragm, it increases the height in the thorax. Okay, as you have seen, in case of relaxed diaphragm, it increases the height in the thorax, which helps in better diaphragmatic movement. Okay, this is about the effect. Coming to the development, the development of the diaphragm itself, it is mesodermal partition with composite origin. Okay, mainly from the septum transversum. So if you see in this picture, this is the septum transversum, which will be in major role in the formation of the diaphragm itself. Okay, so the main structure will be the septum transversum, the anterior-medial part including the central tendon, the vena cava, as well as esophageal opening are all formed by the septum transversum itself. So this is the septum transversum. Okay, extend ventral body wall to the ventral surface of the esophagus. During head fold of the embryo, septum migration from the second cervical to the 12th thoracic vertebra will happen. Okay, the septum migrates from the second cervical to the thoracic. That's why if you see the phrenic nerve, it is coming from the third, fourth, and fifth. Because septum transversum was on the top near the neck, but it descended downwards into the thoracic cavity. And this is at the 12th month, second month, which helps in to trace the phrenic nerve, which coming from the third, fourth, and fifth cervical vertebrae. Okay, and this corresponding with the nerves itself, as we have seen, the right and left phrenic nerves are C2, C3, C4, and C5, because they were actually the septum transversum was in the neck. And it is also invaded by the myotomes of the third, fourth, and fifth cervical segment with corresponding nerves while descending. That is the phrenic nerve as well as the sympathetic supply itself. Okay, so here you can see here this is the septum transversum. One is the septum transversum. Along with that, between the esophageal and aortic opening, there is a dorsal mesentery of the esophagus itself. If you can see here, this is the dorsal mesentery. Okay, there is ventral mesentery and dorsal mesentery here for the esophagus and the inferior vena cava. The aorta is behind, so it doesn't have to. These are the vertebrae and the ribs. So aorta is here. So for the esophagus as well as for the inferior vena cava, there will be dorsal mesentery. Okay. Which also plays a role in the development. Okay. Then the peripheral part by the shelf-like projection of the body wall itself. So the peripheral part will be formed by the muscular ingrowth from all the body wall. Okay, that is formed by the body wall itself. And then also from the pleuroperitoneal membrane. Okay, sorry. So this is the pleuroperitoneal membrane, which also helps in the formation of the diaphragm itself, behind the septum and on each side of the dorsal mesentery. So all this together will form mainly from the septum transversum, then the body wall from surrounding, then the mesentery, okay, the dorsal mesentery, as well as the pleuroperitoneal membrane, which all together will form the diaphragm itself. During diaphragm formation, sometimes there might be some openings left behind, which leads to the hernias. These are called as the diaphragmatic hernias. One is, as we have seen already, the foramen of Morgagni. So this is the small space of Larrey, which sometimes becomes larger, which leads to formation of foramen of Morgagni, present in the front of the sternal origin of the diaphragm, which leads to abdominal visceral herniation. The second is the costovertebral trigone, or the Bouquet's triangle. If you can see here, see, this is the near the costovertebral side, trigone might be formed, which leads to formation of this triangle. And diaphragm fails to arise from the lateral arcuate ligament. Here the lateral arcuate ligament doesn't give rise to the diaphragm, so it fails to develop from there, forming the triangular gap. and abdominal viscera might easily herniate. Whenever there is pressure created by the diaphragm, the abdominal structures or the organs might herniate into the thorax. Usually on the left side. It is more commonly seen on the left side than on the right side. The last will be the hiatal hernia, which is especially near the esophageal opening to the dilated esophageal hiatus. Sometimes the opening might be dilated, which leads to herniation. There are two types of herniation. One is called as sliding, commonest, and this is because of gastroesophageal junction slides and lying, it especially seen in the lying position, and regurgitation, which leads to heartburns. The second type is called as rolling, which goes up and down. So here this is the normal one, this is the hiatal herniation. In case of rolling one, the fundus of the stomach projects by the esophagus, paraesophageal, causing pain as well as nausea as well as dysphagia. So here is the fundus. Sometimes the fundus might project through along with the opening, which might lead to, this is called as rolling, which leads to nausea, pain and dysphagia. So this is about the hiatal herniation. If you have any doubts, you can write to me and I will try to answer. These are my references. Thank you very much. Hi friends, if you like my video and if you want to see similar kind of videos in the future, subscribe to my channel as well as like the video. Press the bell icon so that you can get regular updates and you will be the first to get the updates. Then you can also comment as well as share this video with all your friends so that all can benefit from this. Thank you very much.